My presentation has the topic Being Connected, Cooperation with the Referring Centers. My name is Volker Bärsch. I'm a cardiac surgeon. On the one hand, I'm the head of the section Implantable Cardiac Rhythm Devices in the St. Marien Krankenhaus Siegen in Germany. On the other hand, I'm a member of the lead management group in the Helios Clinic in Siegburg. Here are my disclosures. Well, we are talking about connection and cooperation to the referring centers. What I want to point out is that connection and cooperations work in different directions. These are two very important things of our daily work. Let's have a close look from the perspective of the patient. The patient is influenced from many parties. At first, the family or the primary care physician who care about the patient, who see the wounds, who have daily contact with the patients, and usually the patient is sent to a specialist or a local hospital. But the connection to the Department of Cardiology is mostly poor. The patient can read some information from the industry. He may be in contact with experts or may read some information from the medical society, and at least he's in contact with the lead management center. If you have a close look from the perspective of the center of lead management, the relations are quite the same. There are a lot of ways to cooperate and to connect with. And in my opinion, it is really important to care about all these ways of dialogue. The lead management center has a very close contact to the specialists who send the patients to the center or to local hospitals, or especially to the departments of cardiology who care about the heart patients. But one very important question is, what are the most dramatic facts regarding our topic lead management? Well, I want to take two. The first one, we know that more than 6 in 10 patients with device infection may be undertreated or not treated at all. But we know that the CID infection rate has grown more than 300%. And it shows no sign of slowing. We have a very good data who cares about that. And there's one study I want to manage, the attempted device salvage study, which is published, and you can see it on the homepage of Philips. And the main information is that 53 patients who have been discharged with an infection, 26% died. So we know that only the attempt to salvage is not the good way of treating the patients. The second problem is that the potential procedural risk of lead extraction is highly overestimated. We know that regarding the implantation procedure, there is big data who shows us that around about 10% of the patients are experiencing at least one complication. So it might be very risky to care about the leads if we have to put them out. But like we see in the German gallery results, the procedure-related mortality is only 0.55%. We know that very well-trained centers have been asked how high they guess the procedure-related mortality, and we heard about numbers of 3, 4, 5%. So I think there's a big task for us to show them that it's really, really overestimated. We have several tools to show that the procedure is safe, and at least we see on this other publication, or these 3 publications, that the mortality is low, that the survival rate is high, and that using new tools like the bridge occlusion balloon, we can offer a very good opportunity to care about leads. But the main problem is big number of patients are not adequately treated. What are the reasons for this gap? Well, I think the guidelines are poor known. There's a difference between the subjective risk weighing and the real one. There's a lack of information. Often other departments care about the complications. Especially in Germany, there are heterogeneous structures. There is no or only little intersectional exchange. And lead management is mostly a marginal discipline. Networking is not generally established, and the referring centers have fear of losing the patient. Therefore, the connection to and the cooperation with the referring centers is essential. But it's also important to be connected to the family, to the house doctors, primary care physicians, the specialists, the nursing services, and the patient himself. If we are able to be connected and to cooperate with all these parties, we can have very, very well effects. We can create information opportunities like training events, information events. We should publicate the current research results. We should care about realistic risk assessment. Intersectoral cooperation is a very important thing. I was thinking about heart rhythm teams, like all the heart teams we know in other topics. We should be sure that there's a big awareness of the current guidelines. We have to create discussion platforms. User meetings are very helpful, but we can use just existing networks. Transparency in that what we do and a commitment of fairness are mandatory. Let me show our network between Siegen and Siegburg. On the right side, you see the Department of Cardiology in my hospital, and you see there are a lot of referring centers with which I cooperate, where the very close connections. There's a possibility to have a contact to me and my colleagues just to decide what to do, or if the patients can stay in its hospital to be treated at the home. On the other hand, there's a big connection between the cardiac surgery in Siegburg. Although there's a difference, a very big way between Siegburg and Siegen, we work very close together. A lot of referring centers use this just to talk about cases to find the right decision for the patient. We have heard in other presentations that the safety of the procedure is very important. And there's a connection to the industrial partner, one of the most important things. To be successful in particular difficult cases depends on the disposal of all the tools we need, and therefore we need a very close connection to the industry and a good operation with the field specialists. But we have to be connected to all the team members. While we perform our procedure, is it mandatory to have a good connections and cooperation with all the members of the team, the anesthesiologist, the cardiotechnician, the surgical nurse. We have to use a checklist altogether and safety protocols. And these good cooperations makes it possible to reach a high level of safety. If you have a look into the HRS expert consensus statement, we see in one point, there's mentioned the importance of collaborative multidisciplinary team cannot be overstated. In my opinion, the ultimate ultimate goal is to increase the awareness for the CIED infection and its potential life-threatening risk. I like this very simple words: infection and device is removal. Let me give you two short examples. First patient, 58 years old, male. He got a dual chamber pacemaker for several years. Indication is unknown. The actual problem is the dislocation of the pacemaker, and the primary care physician asked if it's a possibility to manipulate without an operation. I show you the picture. Here you see what the problem is, and it's not possible to manipulate it from outside. We do the operation, and look at that, what we found: a starting Twiddler syndrome. It would be a fault not to reopen the wound and to solve this problem while using an operation. And it was very important for the primary care physician to have a connection where he can ask what to do and where to send the patient. Second example is a 72 years old female. She got a single chamber ICD 5 years ago with a dilated cardiomyopathy. There was a consultative question from the referring center. The problem was, after pulmonary infection with restitution after 3 weeks, she got again fever and leukocytosis as signs of infection. There was no pulmonary focus, but we had a new murmur, and in the TEE there's a suspect structure on the lead like endocarditis. The question was how to treat: only antibiotic therapy, open surgery, or transvenous extraction. What we saw in the TEE is a very, very big endocarditis on the lead, and we decided to extract it by open heart surgery. And if you see this, it was a good idea to do it like that. And again, an example where the dialogue between the referring center and the lead extraction center is mandatory, and in this case, it was the best idea and the best decision to do an open heart surgery. Thank you for your attention.